Back to Allied Health 102, Intro to Phlebotomy. Now, we know that our test is going to be on chapters 13, 14, and 15, right? So, chapter 13, I covered pediatric, and in chapter 13 in your textbooks, it covers pediatric and geriatrics, and then chapter 14 in your textbook is point of care testing. So, really the thing to have done was read chapter 13 in your textbook before you watch the pediatrics, but I'm going to cover the geriatric procedures here, okay? So get out your black binders, and you may have to toggle between your chapter 13 review guides and your chapter 14 review guides to answer these questions, okay? But we're going to cover that. But make sure you're reading chapters 13, 14, and 15 in your textbook. There's a wealth of information in there. And if you want to be successful in this course, also be successful in Allied Health 211, not just your classroom activities where Miss Mullins will be testing you on this same stuff, because we want to make sure you guys are getting these things locked in your mind, so not only you can be the best phlebotomist, but also so you can pass your certification exam, okay? So make sure you read those chapters, make sure you watch these PowerPoint presentations, have your review guides out, fill them in, and then study your review guides, okay? Now let's get started. So as always, and you guys know this, we always talk about our learning objectives because it is important. Anything you do in life, you want to make sure you have goals and objectives, right? These are the things that when you get through reading chapters 13 and 14, when you get through watching these PowerPoint presentations, these are the things that you should know at the end, okay? You want to be able to name other point of care testing terms. You want to be able to discuss future trends in point of care testing and all the stuff in between. So make sure you read through your learning objectives. They're also listed in the front of your textbook at the beginning of the chapter. Okay, so you'll know what's expected of you at the end of the chapter. So let's first start by covering geriatrics patients. In our previous PowerPoint presentation, we talked about pediatric patients. Both pediatric and geriatric patients are covered in chapter 13 in your textbook. Now remember, the elderly or geriatric population comprises about 15% of the population, but it uses about 31% of the healthcare services. So in 25 years, this will increase to 20%, okay? More and more of the time, laboratory testing will take place at the patient's bedside. And we need to remember that physical conditions we see in the elderly, such as arthritis, Parkinson's disease, Alzheimer's, and other debilitating diseases will continue to increase the need of point of care testing by skin puncture because of the difficulty of performing venipuncture on elderly. So this is why I combine this point of care testing with geriatric patients, because they're the segment of the population that is really pushing more of this point of care testing. Because if they're in a facility or a hospital, they're at a greater risk of falls, they're at a greater risk of bone breakage due to falls, due to osteoporosis, and we just want to keep them safe. So it's a lot of time to monitor them better. It's easier to be able to do some of these testing right there at their bedside. You don't have to get them up, you don't have to take them anywhere, and as we know from lab and in lecture, geriatric patients can be very difficult to stick and obtain blood from. So if you're using point of care testing, a lot of that is skin puncture, and it'll be much easier to perform that skin puncture, get the blood you need to run certain point of care testings. So that's why we've kind of combined these two together. So now let's talk about some terms used for direct laboratory services, okay? Guys, remember, these terms are important. You want to understand the language. You want to understand what these words mean. Because first, it's going to help you do your job better and be a better phlebotomist and a healthcare worker, but also it helps you speak more intelligently to physicians, to other healthcare workers, to patients and patients' families, okay? Now, these are some of the things we want to look at, okay? Decentralized laboratory testing, okay? Decentralized means it's not just centralized in the laboratory. On-site testing, right? So if you're in a nursing home, You can do testing right there in the nursing home, in the physician's office, things of that nature, okay? Alternate site testing, okay? That's a site that's an alternate area for them to go to be tested, or for you to test them somewhere else. Near patient testing, which makes sense, right? That's why we see things not just with geriatric patients having a small lab, or be able to do bedside testing in nursing homes, maybe assisted livings, maybe at right there, like I said, in the physician's office. We've seen these kind of things if we have a little small lab right down there in the ER, right? So when those patients come in, we can do that point of care testing, take care of them at right there where they are, right? And in the ICU, we've seen it there too. So all of these words and bedside testing, all of these things mean the same thing, okay? They all mean that lab testing does not have to be done in the big labs that we're used to. We've got lots of little outpatient labs, physician's office labs, all of that. So all of these words are really talking about those types of laboratory testing, okay? And like I said earlier, with the growing U.S. elderly population, healthcare workers will increasingly be performing on-site laboratory testing. Whether you're going out as a part of home health to the patient's home to test their glucose or their hemoglobin or something like that, whether you're going out to the nursing homes, okay, physician's office, there's going to be a growing need for this as the U.S. elderly population grows. So, physical problems common in older individuals and the phlebotomist's response. So these are the things, right? Think of it like this, guys. These are the things that you're going to run into, that you will have to deal with when you are taking care of somebody that is older. As we know, as people age, they lose their hearing, they lose their sight starts to failing, they lose their sense of taste, which then affects their appetite. Their memory may not be as good as what it used to be. I certainly can attest to that. Their skin becomes thinner, okay? Muscle wastage, they start losing their muscle mass. And we're going to go back up here. So when we're dealing with hearing loss, that means that you may need to look directly at them as you're speaking to them. You may need to repeat yourself several times, and you may need to get down and talk closer to them in their ear, okay? Just remember, I always tell y'all all the time in lecture and in lab, you always want to have empathy, right? Not only that, you always want to understand that you're providing great customer service and customer care to these patients, right? And remember, like I told y'all in lab recently, we're all, if we're lucky, going to get old one day. And remember, how would you want someone to treat you? So be patient with them, right? Repeat it as many times as you need to. Get down and talk in their ear. Raise your voice some so they can hear you. And make sure they are understanding you, okay? If you're working around these patients, it's not someone else's job. If you come in and they come into your outpatient clinic, or if you're seeing them in the hospital, you want to help guide them into their seat if they need help. You want to help them and provide the best customer service for them as you can. If they need to go to the bathroom, you want to help them. Guys, it is not someone else's job. You are a vital part of the healthcare team, and when it comes to the elderly people or people with any type of physical or mental disabilities, it is a part of your duty to help take care of them. If that means helping them find another department in the hospital, then you stop what you're doing and you help them, or you get someone else to help them. That is true customer service, and that is doing the right thing, okay? Now, as people age, sometimes they can lose their sense of taste. Now, why does that matter? Because it affects their appetite. They may not eat as much. They may start feeling weak. They start losing their muscle mass. And a lot of times we have to really encourage them to eat, okay? We have to really encourage them to eat. We have to help them if they drop things. We can help them pick it up. Help them make a fist if they need to, okay? These are things that you may need to do to help them as you are assisting them with their phlebotomy. Okay. Now, when it comes to memory loss, you want to check their chart to see if fasted intake meds, if they can't remember. So if you ask them, you might need to explain it to them a way in which they remember. If they're in a facility, then they serve them their food. So if they can't remember if they ate or not, and it could happen, make sure you either check their chart or check with their nurse to see if they were served their meal that day. If they can't remember about meds, you might want to ask your nurse to make sure they're not taking any medication that could cause them to bleed longer, right? And remember, their skin tissue becomes thinner. This makes it more difficult to anchor their veins to prevent them from rolling. So you've got to be aware of that, because as they age and their skin gets thinner, those veins will roll around a lot more, okay? Remember, their muscles become smaller, so you want to make sure you do shallower sticks, because they get smaller arms, right? And those veins are right there, right? They have an increased hypothermia. So we know as we age, a lot of times their hands are colder, even their arms are colder. So make sure you are warming these puncture sites, even in the antecubital fossa of the arm. We want these sites warm so we make sure we can collect the blood that we need, right? They have increased sensitivities and allergies. You always want to ask them if they're allergic to anything, or check with their nurses. You want to be very careful about applying Coban, latex, and things of that nature, okay? They run into a lot of depression or anger, okay? Because sometimes they get treated disrespectfully. They're very sick, they're elderly, but they still need to be treated with respect. And remember, guys, I know it can be difficult sometimes, it can try on you, but you do not need to be in the healthcare profession if you are not going to take a deep breath and treat all your patients with the respect that they deserve, and try to be understanding and empathetic that they are sick, they don't feel good, they're probably scared, they're worried, they're away from home. You too, if you are lucky, will one day be elderly. Remember, how would you want to be treated? How would you want your grandmother treated, or your mother? Always keep that in your mind as you're making decisions. Let's talk about some point of care testing, right? We have a glucose monitoring, right? Because we know that we have a lot of diabetics, right? And not only do we need to test them so that we can diagnose them as a diabetic, but we also need to test them so we can monitor them and make sure their glucose is staying within range. And we need to treat them. We need to decide what treatment method they need based off their laboratory results. And then we see if that treatment method is working appropriately or if it needs to be changed. Okay? The most widely used point of care testing is glucose testing. And there's a ton of different glucose monitors out there on the market that can be used at point of care testing. So if specimens are to be collected in homes, right? You're working for a home health, you're going out to these people's homes, you're drawing their blood, you're doing glucose testing and other testing. Remember, there's extra care that must be taken. You want to take extra supplies with you, especially sharps containers. Make sure when you're going into the home, you're still responsible for disposing of these sharps properly, okay? You still want to make sure you go that extra mile to positively identify your patient and make sure that you get them to tell you their full name and date of birth and compare it to the requisition form you have in your hand and make sure they match. Place them in a comfortable reclining position, right? You may want to transport hand disinfectant so you can disinfect your hands in front of your patient and then don your appropriate PPE. Before you get started with your phlebotomy on your patient, you may want to locate the nearest bathroom, sink, paper, and any towels prior to your procedure. You always want to carefully dispose and remove all supplies. Remember, if it is stuff you can throw in your regular trash, then you can dispose of it in the trash in the patient's home. But if it has blood or body fluids on it, or it is a sharp, then it needs to be placed in a biohazard container appropriate for it, taken back to your facility and properly disposed of. Do not throw blood and body fluids into the regular trash in someone's home. Period. Don't do it. You always want to make sure you label your specimens appropriately. They need to be placed in a leak-proof container for transport. And you want to transport them at appropriate temperatures. We all know how hot our cars can be in June, July, and August, sometimes May in Louisiana. You need to prepare for that ahead of time and make sure you have some type of cooler or something so that you can place your samples in them to keep them at a cooler temperature. If you get caught by a train and you are slower getting to your patient's home, first and foremost, you want to make sure that you alert the patient to the fact that you're held up. That's respect. Your time is important to you. Their time is important to them. Do not disrespect people by not caring about their time. Call them on the phone and let them know that you've been caught by the train, or there was an accident on the interstate, or you got held up by another patient and you're on your way right now. You're very sorry. And then you must document delays in returning specimens to the lab. In other words, if you got held up at the patient's home, if you ran into a train on your way back to the lab, if you ran into an accident on the interstate going back to the lab, you need to document why this delayed happened. Okay, as always, here's our thinking slides, right? This is a way for you guys to test yourself and see if the things you're learning in both lab and lecture, you're able to put together to make sure that when you're out there in your clinicals or out there working as a phlebotomist, you will be able to handle these situations as they come upon you. So pause this one right now and let's go through this and see if you get the answer. Remember, this is why that you have a lot of tools in your toolbox. You don't have to tell you in lab. You have lots of tools in your toolbox. You always want to pick the best tool for the job. And you know that sometimes you may need to draw a gray top tube because it will preserve the glucose if it is not going to be able to be getting back to the lab in the time it needs to. Always, it's like your case studies, guys. Think of every one of these situations. Use your critical thinking skills to think through this and make sure that you're putting it together. That's why we have a gray top tube, right? Because it has a preservative in it that will preserve our glucose values, right? I know we do not like to go back and draw that blood again. I know we hate that kind of situation. No one wants to do it. But always be an upstanding, honest, trustworthy healthcare worker. If you see that what you have done could cause erroneous results, you would not want somebody putting erroneous results out on you, out on your children, or your loved ones. So you just have to, what's that saying? We put our big girl panties on, right? We just have to accept that this happened. We have to contact that patient, explain to them slowly, and so they will understand what happened, and then you will have to redraw that blood. And the next time, you might want to draw it in a green top so that way this situation will not occur. Okay, we're still talking about glucose monitoring, right? So when you're obtaining blood specimens for glucose testing, the main thing you want to do, right, we got to ID our patient. We want to introduce ourselves, identify our patient, right, do our medical interview. Then we want to we want to find the appropriate finger, right? Third or fourth finger. Usually we start with that non-dominant hand, right? Then we see where we're going to put our lancet and right where we're going to stick our patient. That's when we want to cleanse that area with 70% isopropyl alcohol and allow it to do its job, right? We want to make sure our hands are warm, right? Because we get 7 times more blood from a warmed finger. So then we take our lancet, we make a swift, deep puncture, holding it down really, really hard as we depress our trigger, right? Then our lancet goes directly into our sharps container immediately. We wipe that first drop of blood away. And in glucose testing, sometimes you need to watch your manufacturing guidelines on whatever instrument you're using. The particular one we use at Bipsy, you wipe away 3 drops of blood. Then you massage your finger, you apply the Hemocure microcuvette to the drop of blood. Like I always tell you, whatever you're collecting your blood in, you get that big round drop of blood and then you touch that. In this case, It's a micro cuvette that goes directly with this particular monitor, okay? And then you touch it to the drop of blood. The drop of blood by capillary attraction will come in there. Now, in this particular, in the Hemocure, you can use capillary blood, venous blood, or arterial blood, okay? You want to wipe off the excess blood from the outside of that cuvette. Then you place the cuvette into the cuvette holder and insert it into the photometer, okay? Test results are displayed automatically on the screen, okay? Now that's for that particular model, okay? What you always want to make sure is wherever you're working, whether they're using an AccuCheck, a glucose meter, a One Touch, a Freestyle, there is a ton of different glucose bedside monitors out there, and you want to make sure that you follow the specific guidelines for your particular monitor and make sure that you follow the directions. Whatever strip or cuvette goes with that instrument, you want to make sure you use that one. Follow the directions the manufacturer set out for use with their particular monitor. Okay, so quality, okay, in point of care testing, right? So the most predominant ketone in the blood of uncontrolled diabetics is beta hydroxybutyric acid, right? So the hormone released from the pancreas that affects blood glucose is insulin. Remember we talked about this. You eat a meal, right? And then your body breaks down your carbohydrates into glucose, and that glucose is surging through your blood, right? Well, we want to stay in homeostasis, so we want to have our blood glucose level at that range that we want to keep it at, right? So to do that, if we've got too much glucose in our bloodstream, our pancreas releases the hormone insulin, and insulin takes the glucose out of our bloodstream and moves it into our tissues, okay? So we do glucose monitoring. So these glucose monitors, okay, we need to remember that they have to be calibrated. And again, just like I said, there's a ton of different ones out there. A lot of them some use strips, some use cuvettes. Sometimes you have to wipe the first 3 drops of blood away. Some you have to wipe the first drop of blood away. They're used differently. You turn them on differently. Some of them have codes. Some of them have other things. So the first thing that you always want to do is read the instructions on your particular model, which should be in a policy and procedure manual in your lab. Make sure you're familiar with your instrument, not only exactly on how you use it, but if it requires calibration, how often, we know about quality control, right? Any instrument that we're doing testing on has to have quality control ran on it, and what type of maintenance needs to be done and how often does it need to be maintenance. And you should keep that on a log. You should be able to show anyone that walks into your lab some type of electronic or written record that you have calibrated your instrument when it was supposed to be calibrated. You perform maintenance on your instrument per the manufacturer's instructions, okay? And you also want to have either an electronic or a paper record of quality control. And as we know, CLIA says that 2 levels of quality control must be run each 8-hour shift each day of patient testing on all instruments that are used for patient testing. And then we understand either electronically or on paper, control values are plotted on charted and graphed, right? QC values must fall within upper and lower limits called tolerance limits. Tolerance limits are determined by pooling QC data obtained during a 30-day period. Tolerance limits, upper and lower limits, are set based on the fact that 95% of the values will fall within plus or minus 2 standard deviations away from the mean, right? So whatever that mean result is, you have 2 points above that, which would set our upper limit, and 2 points below that, which to set our lower limit, right? And we want to make sure that our QC results fall somewhere in between that. So let's just say, just make this up, okay, guys? Say that our mean is 50. And then our upper limit is, let's just say 52, and our lower limit is 48, okay? So then when we run our quality control, our results should come in anywhere between 48 and 52. And each time we get that result from running our quality control, we want to put it on a chart and graph it. Just like you see in that bottom picture there to your far right. Each day that we run, so down the bottom it'll have each day that we ran controls across the, like it's like an L, right? And then across the other thing it'll have the results that you get on those quality control. And each time you run it, on the day you run it, you'll put a little dot and then you'll start connecting them so that you can see a graph and see how your quality control is trending. So if a daily quality control value exceeds that tolerance limit, right? If it goes too far high or too far low, corrective steps must be taken. Stop testing. Do not test your patients on that machine. If you run quality control on your glucose machine, when you come in the morning, before your patients get there, you're working in a small outpatient lab, right? And you run quality control and they do not come in. You must reject those results, and then you need to start troubleshooting it. You can rerun it. Maybe you made a small error, or maybe your strips have been exposed to too much air, too much moisture, and now they've gone bad. You need to open up a new box of strips. You need to recalibrate your machine. You need to perform maintenance on your machine. You need to keep doing something until you fix the problem. Then you rerun your controls, and your controls come within limits. If you cannot get your controls to come in limit, then that machine cannot be used for patient testing. Remember, specimens, reagents, or controls stored at the proper temperature are outdated. If they're not, they can cause you to get bad results. If you don't let your alcohol dry and it contaminates the blood, it can cause erroneous results. If you don't get the right volume of blood onto the strip or onto the cuvette, it could cause a problem. If you don't wipe the excess blood off, if you don't do it at the proper time, if the instrument's not cleaned, if the reagents are expired, if the patient dieted or fasted, okay? There can be transcription errors where you write something down or the batteries are going out. These are all just a few of the things that could be going on that could be causing you not to get the appropriate results. So here's one of our thinking situations, right? I want y'all to read over this, analyze this situation, think it through thoroughly, use your thinking cap, okay? And then pause it now and see if you're getting the right answer. Remember, you stop using that instrument. Do not test your patients on it until you can get your QC to come in range and you figure out what's going on. Okay, now we're going to talk about blood gas and electrolyte analysis. So in the blood gas analysis, the blood pH determines whether the blood is too acidic or too alkaline. And the pressure of oxygen, the PO2, and the carbon dioxide, PCO2, is used to measure the blood gases whenever a patient has some type of heart or lung disorder. So point of care blood gas analysis is most commonly used for critical patients, such as emergency room patients, ICUs, cardiac patients, things like this. Units where these people have a lot of either heart or lung issues, and you have a blood gas analysis instrument right down there in the ER or right up there in ICU, so that you can draw it and you're right there near that machine. You can run that blood gas analysis immediately and report out results. In addition to monitoring blood gases, point of care instruments such as the Novastat Profile, PHOX POS Plus, right, can measure blood electrolyte levels, sodium, potassium, chloride, and calcium, glucose, bicarbonate, and total carbon dioxide levels. So there's lots of point of care instruments that can be maybe not really at the bedside, so to speak, but in the ICU area that's just steps away from those patients' rooms, right? Or right down there in the ER, just steps away from the trauma rooms, right? that can not only give you blood gas analysis, but can also give you other things like your electrolytes, maybe glucose, maybe calcium, depending on your particular instrument. But it makes us get the results on these critically ill patients to our doctors as quick as humanly possible so they can immediately know what's going on there with their patient and start treating them. So do these instruments require calibration, quality control, and maintenance? Yes. Anytime you have an instrument, even a small handheld instrument you're using at that patient's bedside, if you are running tests on that patient and reporting out results of any kind, then you have to follow the manufacturer guidelines for that instrument along with clear law, which means that 2 levels of quality control must be run each 8-hour shift each day of patient testing on all instruments. Okay, so like I said, guys, any instrument, whether it's handheld and you're using it at that patient's bedside, or this is a bigger, more expensive instrument sitting in the ICU or the emergency room, you must follow not only the manufacturer guidelines on how it's used, how it's calibrated, and the maintenance that needs to be done on it, and that all needs to be recorded and documented somewhere electronically on paper. But CLIA law says 2 levels of quality control must be run each 8-hour shift each day of patient testing on any and all instruments. So there's a myriad of different kinds of point of care testing out there, right? And a lot of it, if you'll notice, it's these chronic or serious diseases like, heart and lung problems. We want to make sure if your blood gases are not in line, that is serious, and we want to get on top of that immediately to do something about it, or our patients could die, right? If our diabetics are not monitored, not only could they suddenly die from just a really high glucose and go into ketoacidosis, but also remember, it is doing damage to their arteries, it is doing damage to their tissues, and they could lose toes, feet, their kidneys could stop working, they could lose their eyesight. So we want to monitor their glucose levels so that we can keep those glucose levels as low as humanly possible. And also, we know heart disease is the #1 killer globally, right? And so we have a lot of different cardiac point of care testing that we can do right at that patient's bedside, at our physician's office, right? So that we can spot this heart damage quickly, so that we can quickly start treating our patient to decrease their chances of other issues, right? We want to save our patients. So these are some of them. This cardiostat US, right? Troponin T, myoglobin, and creatinine kinase MB, which is CKMB. That is the muscle that is for the heart. So that lets us know that whether it was the steering wheel during a wreck that hit our chest and damaged some heart muscle, or whether we're having a heart attack and some of that heart muscle is dying and damaged, that CKMB is what tells us that, okay? So then that troponin T, right? All of these instruments, if you'll see the instrument at the top when it says cardiostat US, right? It tests for that troponin T, that myoglobin, and that CKMB. And then that TROPT right there, that TROPT, that is for troponin T, if that's the particular test you're looking for. So the hormone released after a myocardial infarction is troponin T. So remember, troponin T is a hormone, and that's what's released after you've had a heart attack. And CKMB is what lets us know that there's been damage to that muscle, muscle, but it's the heart muscle specifically, okay? So these are different ways we can try to figure out if this person has had some type of acute heart damage from either an injury or from a heart attack. Okay, so blood coagulation monitoring. So coagulation instruments for prothrombin time, or PT, these are a list of them. We have everything from the CoaguCheck, ProTime, right, all the way down to our INR ratio meter. So coagulation tests monitor anticoagulation therapy. such as if our patient is on warfarin or Coumadin or heparin. So we're monitoring to make sure they're getting just enough so that they don't clot, but not too much, right? This is a very delicate balance, and we want to monitor these patients, and these are some very key point of care testing at the physician's office or by the bedside, so we can keep a check on how much medicine they need to have. Again, do these instruments need to be calibrated, quality control and maintenance done? Yes, right? Like I said, any instrument needs to follow not only the manufacturer guidelines on calibration and maintenance, and it needs to be documented electronically or on paper, but you also need to be running and documenting your 2 levels of quality control every 8-hour shifts when a patient has been tested on any and all instruments. Then we have hematocrit, hemoglobin, and other hematology parameters, right? So the hematocrit, right, that's our packed cell volume, and you guys in lab have done some hematocrit testing, right? You've seen that testing being done in there. There's other ones, right? That hematocrit is usually expressed as a percentage. That's what you guys did in lab. And the hematocrit values and hemoglobin values aid in the diagnosis of anemia. The hemoglobin test is more accurate than the hematocrit test in the diagnosis and treatment of anemia. The HemoQ beta hemoglobin system is used to measure hemoglobin. Okay, and remember we talked about that HemoQ, we also talked about that instrument when we were talking about doing glucose. So that's the other analyte that the HemoQ instrument can test for. So it can test for hemoglobin and glucose. Then we have the iCore automated cell counter, right? It's used to determine hematology parameters, including, remember, parts of our CBC. White cell count, red cell count, platelet, hemoglobin, hematocrit, right? And platelet aggregation. Then we have the Accutrin GC AccuCheck InstaPlus. It's a point of care testing. It tests for cholesterol, and it can also test for your blood glucose. Because as we know, a lot of times if you're diabetic, you may be morbidly obese, which could lead to bad diets, which will lead to high cholesterol, right? Point of care meter used to screen cholesterol level is the Accumeter. The Accumeter is a disposable one-step quantitative method. It uses no instrument. After blood collection, visually elevated color bars in like a height will show you about what your level of cholesterol is, okay? Now, if that Accumeter, does it require QC calibration and maintenance? No, because like I said earlier on the slide before, it is not an instrument, right? So if it's not an actual instrument, it may have some type of built-in QC. Some of them do, some of them don't. Again, you want to read the package insert that comes with it and follow the directions. And you also want to follow them to a T. And if it has a built-in QC, you want to make sure that is done properly. Okay, let's look at some future trends, right, for laboratory testing. Patients will be more in control over their own health care. That's what we're hoping for, right? Our cell phones, which are those little computers that are in our pockets, they are getting more and more where they're used for monitoring patients, like your heart rate. I think they're going to, in the future, it's going to be used for testing. We're going to be able to put some kind of strips on our phone, and you're going to be able to test via the phone. It's just a matter of time. Now, it also brings up some safety concerns, right? Make sure that you understand that a lot of these devices like this are not as accurate as those bigger machines. Like the machines that take your blood pressure in the drugstore, they're not as accurate as when your doctor does it manually in the doctor's office. But these are good monitoring device that can catch things early, right? Also, we have a lot of that genetic profiling testing. Y'all have seen that 23andMe and other things on the internet. These are some future trends. It does bring up concerns that knowing a person has a genetic condition may cause them not to be able to get insurance or a job. So those are things that we want to make sure doesn't happen. We want to take this really good abilities that we have, because knowing if somebody is more apt to have some type of genetic condition can help us get on top of screening early. If you know you have a gene that makes you more susceptible to certain cancers like breast cancer, then we would want to start screening, doing your mammograms earlier so you can catch the cancer earlier, because it increases your longevity in life, right? If we know you are prone to Alzheimer's, then we can get you on medication earlier. We see all the great things that this type of genetic testing can do. We just want to make sure that people don't use it in the wrong way to deny people insurance or jobs. Also, wellness testing, okay? This particular company was worth $9 billion. It was owned by a 30-year-old woman worth $4.5 billion, the youngest billionaire, okay, at that time. They did 70 plus CLIA-waived certified tests, okay? It was based on microfluids. Okay, some kind of secret principle. 2-3 drops of blood collected into a tiny micro container. It was cheap, cost less than half of what Medicare pays in reimbursement. It decreased turnaround time. Patient had a right to have the results forwarded to their doctor or not, and it was performed at places like Walgreens, okay? But it was in a small market to see if this was something that was going to work. And when I say that, sometimes stuff looks really good on paper. It's cheap. You get a result. It can be done quickly anywhere, but that doesn't always mean that it works, because you may not be getting the best result, and it's somebody on top of making sure that all types of quality control and training are being done. Also, new additions of point-of-care testing. We had that DACA 2000 Plus, that analyzer which measures hemoglobin A1C for maintaining blood glucose levels. And as we know, hemoglobin A1C right now is the gold standard. So the more we can do those kinds of point-of-care testing on that would really help us monitor, diagnose, and treat our diabetic patients better. Then there's the BiliCheck, which measures bilirubin in the forehead skin of newborns. So we can quickly get our bilirubin results, so we'll know and we can see when it's down. We can get them under that Billy light, right? And then there's the AuraQuick, which is an assay for HIV. You want to know your number. You want to make sure if you're HIV positive, you're aware of that, so you can be on medication early, and so that you will know that, so you can be safe when dealing with your sexual partners. Some other future trends are that we're moving more and more to point-of-care testing, right? So for each test, the phlebotomist must learn the certain blood collection requirements for that particular test. It's like I told y'all, you need to understand each one of these instruments may require different collection requirements. It may need to be collected from a finger. It may need to be in a certain container. It may be in a strip or a cuvette. The preventative maintenance that needs to be done to these machines, okay? The QC requirements for these particular instruments, along with calibration requirements, and the ethical and legal implications of the test results, okay? And specific record keeping. All these things phlebotomists must keep in mind, because these are the things that if we're moving to more and more point-of-care testing, phlebotomists are going to be more involved, and they need to be aware of the things that they need to do. Because remember, if you don't document it, it didn't happen. All right, guys, that's the end of this chapter, okay? So in this chapter, we talked about other point-of-care terms, right? The elderly, point-of-care testing for glucose, blood gas, for people having heart damage, coagulation testing, our hematology tests like hematocrit and hemoglobin, cholesterol testing, and the future trends in point-of-care testing. So this is chapter 14. I already have chapter 13 up, which is our pediatric chapter. This covers our geriatric chapter and our point-of-care testing. Make sure you've read those 2 chapters in your textbook. Fill out your review guides and study those review guides. I'll have chapter 15 up soon. You guys have a great day.